Good morning. Today we're going to talk about chronic pulmonary dysfunction and go through many of the diseases that you might see in the acute care setting when treating pulmonary patients. So our objectives are to review a little bit of the anatomy, recognize the most common diseases, and be able to categorize those into types of pulmonary disease. Define some of the interventions that will happen in the hospital. You'll be reading these things in the chart and need to know what they mean. We'll review monitoring criteria for your pulmonary patients, practice some of the breathing techniques in lab that we will need to teach these patients, look at the pharmacological and other types of medical intervention that they may be receiving, identify postural drainage positions and techniques, also known as chest physiotherapy or chest PT, and then later we'll be synthesizing treatment plans for pulmonary patients in the lab and also in the sim lab. So just a quick review, normal breathing ought to be completely due to the contraction of your diaphragm muscle, which is a parachute-shaped muscle, so that the contraction causes it to flatten. It's very, very convex in the relaxed position. So inhalation is where you're contracting muscles. The exhalation should be completely passive. We know that many of our pulmonary patients are going to use a lot of accessory muscles. And so when we start teaching breathing techniques, learning to use the diaphragm correctly will be one of our goals. Here's a quick review of the upper versus lower respiratory system. The upper respiratory, when you have an upper respiratory infection and you go to the doctor, it's usually up in your nose or nasal cavities or sinuses. Whereas if it affects the lower respiratory system, we're talking about everything from the larynx, trachea, bronchi, bronchioles, on down into the lungs and the alveoli themselves. Distal airways are made up of the terminal bronchioles, respiratory bronchioles, and then the alveolar sacs. This is where the actual exchange of oxygen and carbon dioxide takes place. Do recall that your airways have this smooth muscle, and some of the problems that we'll see with respiratory conditions has to do with the constriction of that smooth muscle. Okay, so a couple of important vocabulary words on this slide. First off is the word parenchyma. Parenchyma just means the tissue that makes up the organ. So lung parenchyma just means the tissue that makes up the lung itself. There is interstitium, which is connective tissue inside the lungs. The pleura, which is the lining or covering of the lungs, the pleural membranes. We have both an inside, a visceral pleura, which is the part that covers the inner lining of the lungs, and then we have the parietal pleura, which is the outside. Let's see. Alveoli, we already mentioned, is where the gas exchange takes place. Chest physiotherapy, again, is aimed at keeping air spaces open and free of mucus. We will learn some techniques for that a little later on. The epithelium of the respiratory tract is very, very sensitive to particles and also to touch. Like if you breathe in allergens or dust particles, it's usually this area right here, the carina, which is at the bifurcation here between the trachea and the left and right main bronchus. There's an area there that's full of very, very sensitive nerve receptors, and that's what typically causes you to cough, is the carina. Lung anatomy, it's a little bit complex when you look at the left and the right sides, because the left side's a little different because it has to work around the heart. So the right lung has 3 lobes, upper, middle, and lower, and then 10 segments that branch off of the bronchi, those bronchopulmonary segments that make up those lobes. The left lung has only 2 lobes, an upper and a lower, and it has 8 bronchopulmonary segments. On this slide, you see how the 10 bronchopulmonary segments of the right lung correspond to the 8 segments on the left lung. They both have an upper lobe, right? The upper lobe of the right lung is broken down into 3 segments, anterior, apical, and posterior, and 2 of those are just combined on the left lung. And we have an anterior and one that's an apical posterior. Okay, in the middle lobes, you have on the right a lateral and medial middle lobe, whereas on the left you have a superior and inferior lingula. So those don't even have the same names. On the lower portions of the lungs, again, you have 5 on the right and only 4 on the left because 2 have been combined. Your anterior basal, medial basal have been combined on the left into an anteromedial basal. Please note that every time you see the word basal, when it refers to a lung segment, that means it's actually at the very bottom of the lowest portion of the lung touching the diaphragm. Going into the lung diseases now and the most common types of lung diseases, we're going to start with looking at big categories. You have obstructive lung diseases, which makes it very difficult to get air out of the lungs. The picture over here is supposed to be a pair of worn out underwear, and the elasticity is gone. Okay, so if you have a pair of underwear and they're all stretched out, then you can't fix that really. It's not ever going to go back to its original shape. So when the lung tissue gets all stretched out, you're going to not be able to get the air out of the lungs, or it could be obstructed by mucus plugs, or it could be obstructed by constriction. So these are the 3 main reasons why you can't get air out of the lungs with an obstructive disease. Now, restrictive means that the lung tissue is tight and you have trouble getting air into the lungs, and the lungs cannot expand. So you can't fix that either. So you can't fix missing elasticity, and you can't fix the inability for the lung tissue to expand. So the next slide shows a little illustration with a restrictive disease. The lungs are unable to fill with air because of that tight restriction and inability to stretch. Whereas obstructive, you've got this saggy baggy tissue that has lost its elasticity, and air is just in there, and there's no recoil of elastic lung tissue to push that air back out of the lungs. If we put our main types of disease into these 2 categories, there's only 4 main obstructive diseases. That's chronic bronchitis, emphysema, bronchiectasis, and cystic fibrosis. If you memorize those 4 and you know all of the obstructive lung diseases, then everything else we come across is going to be restrictive. Now, asthma is kind of a category to itself. It's an exception to the rule because it doesn't fit perfectly into either one of those categories. But asthma is one of those temporary conditions that is reversible. The symptoms are reversible. So an asthma attack makes it very difficult to breathe, and it is kind of restrictive in that you have the constriction of those airways. But it doesn't fit perfectly into either category, so it's kind of all by itself. Chronic bronchitis is the first one we're going to talk about. Chronic bronchitis is characterized by a very productive cough for 3 months, at least 2 years in a row, and it is characterized by both the swelling of the bronchi, which causes restriction of those airways, and the buildup of a thick, sticky mucus. So the combination of mucus production and swelling and inflammation of those bronchi, causes this patient to have a real difficult time with exhaling air. Chronic bronchitis continued. When you think about the patient with chronic bronchitis, obviously there's inflammation of those bronchioles, mucus hyperexcretion. That thick sticky mucus is plugging up those airways. They're going to have a really productive cough. That causes air to be trapped, which makes it an obstructive disease. Hypoventilation and dyspnea, therefore they build up some CO2 in their lungs, but their low oxygen in their blood and hypercapnia together cause them to experience cyanosis. So you will frequently hear these patients categorized as blue bloaters, which means they take on a lot of fluid retention, which makes them swell up peripherally, and they have that cyanosis. Okay, so those being two of the primary characteristics. The treatment for chronic bronchitis is obviously, reducing the risk factors, because many of these people are heavy cigarette smokers, supplemental oxygen, and they will have inhaled steroids, mucolytics, bronchodilators to try to help them be able to breathe better. Emphysema is the next disease we'll be talking about. Emphysema is permanent loss of elastic recoil due to the destruction of the alveolar sacs. So you can see here the alveoli get really dilated. That traps air within the lungs and it makes the lungs larger in volume. These patients don't have a lot of thick sticky mucus. They have a dry cough. They don't have any problem getting air in. They have trouble getting air out because air has been trapped in the lungs. Emphysema continued. Again, these patients are typically have a history of smoking or are still smokers. And the typical cause of emphysema is that long-term smoking use. They're not cyanotic like your blue bloaters. These patients have a very ineffective cough. They trap air, so they are often referred to as barrel-chested because the trapping of air causes the lung volume to increase over time, and those alveoli, as they break down, just get bigger, and the air is kind of stuck in there and they can't get it out. When they try to breathe out forcefully, then they have the closing off of airways. So you'll see these patients participate a lot in pursed lip breathing, which we'll talk about a little bit later. Another thing you'll note with these patients is that they have an increased workload with breathing. They've got lots and lots of dyspnea, but just the work of breathing alone is very, very difficult for them. They're frequently called pink puffers. So emphysema and the pink puffer means they're not really cyanotic. They've got some oxygen because of the air trapping, but the workload and the use of their accessory muscles to breathe, the barrel-chested appearance, ultimately emphysema is going to contribute to COPD that we'll see here in a moment. It can lead to pulmonary hypertension, which can lead to right heart failure and cor pulmonale. And if we go back a couple of slides, you'll see that your blue bloater already has typically right heart failure, fluid retention, weight gain, and that's part of what puts them in the category of being a blue bloater. But the two diseases are linked in a number of respects, including how they're caused, and also their treatment. We're going to treat this individual with bronchodilators, inhaled steroids, and supplemental oxygen. That's going to be not us particularly, but the medical treatment of that condition. The next condition is bronchiectasis, and bronchiectasis is just widening or dilation of the bronchi and the bronchioles, which you can see up here in the upper left is a lung with bronchiectasis, and then you have some tissue sampled down here from a lung that's normal. And you can see that the bronchi are much narrower and much wider and kind of scarred in this upper picture. Patients that have damage and scarring from chronic pneumonia, multiple, like if they get pneumonia every winter or they get bronchitis every winter and multiple types of lung infections, then the mucus tends to pool and widen those airways, and the infection and inflammation causes that scarring and obstruction. So what exactly is COPD? Well, we just talked about 3 diseases that are obstructive in nature, and I did tell you already that there were some links that connect these things. Emphysema, chronic bronchitis, and bronchiectasis together are what make up the triad of chronic obstructive pulmonary disease. So it's all 3 of the obstructive diseases rolled into one. And they may start out with only emphysema or only chronic bronchitis, or they may have one to a greater degree than the other 2. But it is very rare for a person to have any of these diseases for very long before they begin having complications relative to the other 2 as well. Most people have a combination of all 3, and that's why we lump it together and call it COPD. So on this image, you can see a patient with COPD in the upper left-hand photo showing that increase in the anterior-posterior diameter of his chest, that barrel-chestedness. Wanted to point out on the x-ray of this individual that you can see that increase in the chest diameter as well as the flattening of the diaphragm. So I grabbed a normal x-ray because I wanted you to see the difference. Okay, first of all, it's very convex. Okay, you can see that the diaphragm really reaches up into the lung so that when that diaphragm drops and flattens, you're creating that negative pressure that draws the air into the lungs. There's no really place for this muscle to go when it contracts. It's not, the lungs are already as inflated as they can get, plus they've got all of that stretched out or destroyed alveolar tissue that's trapping air, and then the compressed airways. So it's very, very difficult for a COPD patient to get air out of their lungs. Okay, so the next condition that we're talking about is cystic fibrosis. This is a genetic or hereditary condition. You see it in children because you're born with it, and it impacts the way that the cells that produce both their lung mucus, their sweat, and their digestive juices, there's something genetic there that causes that to be very, very thick and sticky and excessive in its production. So it can clog up the lungs and obstruct the pancreas. It can cause them to have digestive issues. And it also makes them sweat out a lot of salt. So they're always needing to replace that salt in their body. It is a life-threatening condition. The children that have this have a shorter than normal lifespan, and they're getting chest PT daily for their condition. In fact, many of them have to have family members taught to participate in that as well. So people who have cystic fibrosis have very salty tasting skin, which is a weird thing to say, but a lot of times it's the mother of that baby that is the first one to notice that there's something going on, because new mamas are always kissing their babies, and babies aren't supposed to taste like a salt lick. But they will do, in order to diagnose cystic fibrosis, they'll actually do a sweat test, and they will test the degree of salt in the excretion of their perspiration. So the things that they will have include persistent cough, where they're coughing up phlegm, frequent lung infections like pneumonias and bronchitis, wheezing, shortness of breath. It also affects their weight gain and appetite, like they're not going to be able to eat, in spite of, they have a good appetite, but they can't really gain weight because of their digestive issues. And and they have difficulty with bowel movements. And so you can see some of the things they get over here related to digestion and those symptoms that we've already talked about. They'll get the clubbing in their fingers and the barrel-chested appearance as well. So what do obstructive lung diseases in general look like? We've got them all lumped together. Cystic fibrosis was also obstructive, and so we're summarizing the obstructive ones. If you'll remember, the bronchiectasis, the chronic bronchitis, and the emphysema together made up chronic obstructive pulmonary disease, or COPD. The only other obstructive one was hereditary. That was cystic fibrosis. So what do they have in common? They prevent air from leaving, they loss of elastic tissue, the flattening of that diaphragm, mucus plugging in the airways. Either contraction of smooth muscle that surrounds the airways can also lead to obstruction. And lungs with obstructive disease do not return to normal healthy function. This damage is permanent, and having to teach the patient how to deal with the permanent damage that's been done to their respiratory system is kind of the role of both respiratory therapy as well as physical therapy. So you'll see that it decreases their normal vital capacity. They don't have a normal vital capacity anymore because they've got this huge amount of residual air that can't ever get out of their lung. Okay. Asthma, remember we said, is kind of on its own. It doesn't fall into any category perfectly. And it is a reversible condition because you can prevent it from prevent the attacks, and you can also treat the allergy and the signs and symptoms that would lead up to the attacks. But they can have a lot of excess mucus and a lot of constriction of the bronchioles during those attacks. Moving on now to pneumonia. Y'all know what pneumonia is. It's fluid or infection within the lungs. Up here, the x-ray shows nice dark tissue, so that's normal lung tissue, whereas down here you have some interstitial, which means between the cells of the lung parenchyma itself. So you can have infection of the lung tissue, or you can have infection that is specific to a single lobe. Lobar pneumonia can be confined to one specific lobe, or it can just be in the airways, the bronchioles. It usually is an accumulation of pus and phlegm, and can be due to bacteria or viruses or other type. You can have a fungal pneumonia, which is really, really hard to get rid of. So this picture kind of sums it all up. The patient's going to have cough, fever, chills. They could have tachycardia and tachypnea because they can't breathe real well, and dyspnea. Lots of your patients that are in the hospital are going to have pneumonia. Moving on, atelectasis or atelectasis, depending upon who is pronouncing it, is a collapse of the lung that involves usually one of these four causes. Airway obstruction can cause a portion of a lung to deflate and be collapsed, where you can't properly ventilate that piece of lung due to a obstruction. Hypoventilation, meaning the patient's just not breathing deep enough, and they can begin to have segments of their lung become collapsed when they are very, very depressed in their respiration. Compression due to buildup of fluid maybe, or something else that's pushing on the lung tissue, and then you can also have the formation of adhesions. A lot of time the adhesions might form because of infection and or cancer or other type lung diseases or conditions. Atelectasis is typically unilateral, meaning that you only get it in one side. And it's the collapsing of the lung from some cause that is within the lung itself, whereas a pneumothorax is the accumulation of air in the pleural space outside of the lung, And the fact that it now has air outside of the lung compressing it prevents the lung from being able to expand and fill that space. Normally a pneumothorax occurs because there's a rip or a tear in the pleural membrane and allowing air to come in. So usually this occurs due to some kind of a traumatic event, a rib fracture that happens in the middle of a car accident or something like that. A tension pneumothorax is when the lung shifts and begins to put pressure on the other lung and or the heart, and can become an emergency situation. Of course, a collapsed lung is an emergency situation anyway. Next, we have a pleural effusion. A pleural effusion is when you collect excess fluid. It's outside the lung, but it's inside the pleural lining of the lung. So it's like a water balloon, and that's going to compress lung tissue. Remember that the pleura is that thin membrane that surrounds the lung. It's got a little bit of fluid all the time, about a teaspoon or so of fluid that keeps the lung able to move or glide freely across that pleural membrane. It's kind of a slick, lubricating fluid. But when it starts filling up with lots of fluid, that can cause a problem because it begins to compress on the lung tissue. That can be caused by inflammation, shortness of breath. I'm sorry, it's not caused by. It can cause inflammation of the lung tissue, shortness of breath, pain, and pleurisy. And if you've ever had pneumonia, you've probably felt pleurisy because it is pain every time you take a deep breath. It's deep in the base of your lung typically because fluid always falls to to the base of the lung, and it's usually accompanied with fever and with a cough. On this slide, you see that a pleural effusion, which is just liquid in that space, is different than a hemothorax, which is blood in the pleural space. So both of these might be addressed with a chest tube in order to remove the fluid and take the pressure off the lungs, or a thoracentesis, which can also remove fluid. And then, of course, if you're bleeding, they have to treat the bleeding source. Pulmonary edema. Pulmonary edema is just a collection of fluid within the alveoli, which prevents the exchange of oxygen and CO2. So fluid backs up into the alveoli anytime you have left heart failure. We talked about that in our cardiac lecture. And so that is your typical cause for pulmonary edema, is a weak left heart pump. Remember that the blood from the lungs, once it is oxygenated, is coming back to the left side of the heart to be sent to the rest of the body. So if the left heart is weak, then you're going to have that blood backing up into the lungs. And that's what causes the pulmonary edema, is that there's so much pressure in those arteries that fluid begins to leak out of the arteries and it accumulates in the alveoli. Now, there are some other things that can cause pulmonary edema. One of those is high altitudes. You can get high altitude pulmonary edema. You can get high altitude cerebral edema, which is the swelling of your brain. That's really bad. Or acute mountain sickness. All of those are altitude illnesses. They really don't know. I mean, it has to be related to the partial pressure of gases within your lungs, but they don't know the exact cause of the pulmonary edema from high altitudes. You can also get it from other things as well, but remember that the primary cause is left heart failure. It is a medical emergency. The patient's going to present with dyspnea, sweating, wheezing, coughing, frothy sputum, so they'll be coughing up really frothy sputum that's full of air bubbles. They will be blue, cyanotic around their mucous membranes, tachycardic, and have that drop in blood pressure as well. So in summary, your PTA licensure examination usually puts a good bit regarding cardiopulmonary diseases. And if you're asked a question about whether something is restrictive or obstructive, if you will remember that obstructive diseases are emphysema, chronic bronchitis, bronchiectasis, which make up COPD, and then cystic fibrosis, asthma is all by itself, and then anything else they throw at you is going to have to be restrictive, because those are the only obstructive ones. And if you'll just memorize those, it can help you think your way to the correct answer in a lot of questions where you don't really know the correct answer because it might be an unfamiliar condition. All right. Moving on, let's look at pulmonary embolisms now. We've had a few discussions about pulmonary embolisms related to DVT. That is the most common cause, is a DVT from the lower extremity, and signs and symptoms are going to be indicative of an acute emergency. So you're going to want to call the nurse immediately if this is a hospitalized patient, or 911 if you are treating a home health patient or an outpatient. Rapid onset of tachypnea, chest pain, anxiety, dysrhythmia, lightheadedness, hypotension, tachycardia, and decrease in their oxygen saturation. So if they start to desat in a hurry and you're seeing them drop in oxygen saturation, then that's definitely all the signs and symptoms of them having thrown a clot. You need to activate EMS immediately. We spoke of thoracentesis a moment ago. This is a procedure where they go through in between the ribs with a needle, and they draw the fluid off, and the fluid is drawn off either into a bag like this, and when it is something where they just need to get the fluid off, they'll do a thoracentesis. If there's a continuation of fluid buildup, then they might do a chest tube. Thoracentesis, if they did it that morning, you might want to consider scheduling PT following the procedure, and once the patient is cleared by chest x-ray, since the patient should be exhibiting a lot less dyspnea once they get that purulent fluid. And you can see over here that it is very, very purulent, indicating that the patient did have a lung infection. And you're definitely going to want to monitor their oxygen saturation after they've had a thoracentesis. It should be much better. Bronchoscopy is a procedure where they take a little camera and they go down into the lungs in order to view the airways. And it might require the patient to be on some supplemental oxygen for a while afterward. If you see on the chart that they've had a bronchoscopy, you're probably going to want to check with the nurse and make sure that you don't need to put your PT on hold and that it's okay to go ahead and get them up. Thoracotomy. Many of your patients will have had a thoracotomy. It's a surgical procedure to gain access to the pleural spaces. VATS is when they do video-assisted thoracotomy so that they don't have to make a huge incision. That's what you see here in the left-hand side of the picture. They use a few little buttonholes, and they're able to go in and access the pleural spaces. An open thoracotomy is the only kind I ever saw when I was in clinical practice. They weren't doing the VATS back then. So the open thoracotomy will go from the almost from the scapula all the way down the whole lateral side of the patient across the rib cage. They put them in this position with their arm up overhead in order to open that whole side out in order to do the open thoracotomy. Typically, after they do the thoracotomy, they are going to go ahead and place chest tubes. And chest tubes, I believe, is coming up on a... Yep, there it is on the next slide. So a chest tube is placed. You can see the scar still from the open thoracotomy on this patient. And a chest tube helps to drain the air, the blood, the fluid, regardless of what it is, out of the patient's pleural spaces. They'll call a chest tube thoracotomy when they do it in order to place the chest tube specifically. It is an emergency procedure, or sometimes they put a chest tube in after surgery. So if the patient went in for a lobectomy because they had lung cancer, or they went in for any kind of open chest procedure, they might come out of surgery with a chest tube already placed. Now, the chest tube, you're going to get to see one in the sim lab. It's important to know that they usually place it on a water seal so that they can create suction that is sterile. And they're collecting the fluids over here. They're taking measurements of the different kinds of fluid, and the fluid is going to be collected in a variety of different chambers. If you ever kick a chest tube over, you're going to be in big trouble with the nurse. Most of the time they have little tripod feet that'll rotate to give it a wider base of support so that it's a little harder to knock over. Worse than knocking it over is putting the bed down without checking underneath the bed, and if the bed frame contacts the chest tube and crushes it, you're going to lose your water seal. That's a big deal. So you want to always check with your patients that have chest tubes that it's in a safe position for you to raise or lower the bed without it being in danger. PT management of patients with pulmonary disease is our next topic, and that's going to bother me if I don't change it. In the acute setting, you're going to encounter a number of patients with COPD being your primary diagnosis. Typical presentation includes chronic cough, sputum production, shortness of breath. Most of the time they've been ordered for PT because they're really weak. They have dyspnea with exertion, and they need help performing ADLs or getting back up and moving. You don't want them to have any additional complications like pneumonia on top of COPD, so you want them up. You want them exchanging air, and you want to help them become as asymptomatic as you can. The prognosis of COPD is poor because, like we said earlier, it's not really a reversible condition, but helping them manage their symptoms and helping them to use their breathing as efficiently as they can is part of what we do. Arterial blood gas is one of the things that you might see on the order pulled for this patient to check their PaO2 and PaCO2 to make sure that their pH is being well balanced. We don't want them to go into respiratory alkalosis or acidosis. So this might be something that you see on the chart that's ordered for your patient with COPD. But what you're going to be doing in your physical therapy is monitoring oxygen saturation. Remember that these are different things, that this is done with a blood draw, this one is done by monitoring with that O2 sat monitor. You want your patient in the 94 to 100% range, but y'all, many of your COPD patients are going to be considerably less than that. Spoke with a good friend of mine, actually, whose family member, loved one, was in the hospital with COVID last week, and this patient is no longer on a ventilator. They're off the ventilator. They are on 4 liters of oxygen, and if they get up to walk to the toilet, their O2 sat drops to 70%. So we did tell you that below 90 was an emergency, but when you have a patient who is that sensitive to exertion, and some of your COPD patients will be that sensitive to exertion, then you don't want to be calling the nurse every time it drops. You want to look at what their typical O2 sat is, how much distress they're in, their level of dyspnea, which we'll talk about in a minute, and kind of go from there, because you might have some patients that run really low O2 sats. You already know 94 to 100 is normal. As a general rule, less than 90% is hypoxemia, and that would cause you to discontinue therapy. If you're dealing with a normal patient that does not have COPD, they're in the hospital because of a total hip or a total knee or whatever, and all of a sudden they drop below 90%, then you're immediately going to start thinking maybe that patient threw a clot, and they might be in acute respiratory distress, and that would be the need to call the nurse immediately. Especially if they have the dyspnea, cyanosis, diaphoresis, pallor, some of those other things that accompany DVT that we talked about. But your patient with respiratory disease, COPD specifically, you want to check with the nurse, find out what their O2 sats have been running. And another really strong warning is to never, 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 never increase their oxygen unless there's an order on the chart by the physician and unless respiratory tells you it's okay. If you see an order, it's going to say something like titrate the O2 up to sats greater than 95% and monitor sats during treatment as indicated. If it says that, then it would be okay to turn it up a little bit. I would still seek some guidance as the PTA from the respiratory therapist or the nurse regarding how much is enough or how much is okay to turn up their oxygen. If they're on 2 liters and you titrate it up to 4 during exercise to keep them in a good saturation, then that might be okay. But with patients that have pulmonary disease and who already have trouble exchanging oxygen for carbon dioxide, increasing the oxygen can decrease their drive to take another breath. Many of your chemical indicators to take a breath are a whole lot more driven by the PaCO2 than they are by the presence of O2. So your body's not looking for, hey, I'm not getting enough oxygen, I need to take another breath. It's saying, okay, I've got too much CO2, I need to breathe out, which indicates that I would then need to breathe back in. So if you give a patient way too much oxygen, you can actually decrease their drive to take another breath, and that can be very, very dangerous from a biochemical respiratory center standpoint. So just make sure that you have an order or you don't touch the oxygen. If it's on 2, you leave it on 2. If you take it off the wall and you put it on portable to go down the hall, you put it on 2. When you come back, you make sure that the wall is still on 2. My advice to you is that it doesn't hurt to leave the wall oxygen running. If you pull the tubing off the wall, leave it on whatever it's on, change it to the portable, turn the portable on, make sure that you, when you get back from walking the patient, just connect the tubing back to the wall. I wouldn't even mess with the level of the wall oxygen because it's not hurting anything for it to continue running. When we walk a patient that has a pulmonary condition, we're always going to monitor their shortness of breath, and there is a scale called the dyspnea scale, and it's very similar to another scale that you've seen that has to do with exertion, that Borg's relative perceived exertion or rate of perceived exertion. So this is another scale that says 0 dyspnea means that I'm not having any trouble at all taking a breath, whereas 10 would be very, very severe, almost maximal, and then maximal would be even higher than that. If you tell a patient on a scale of 0 to 10, with 0 being no difficulty breathing at all and 10 being very, very severe, you let the patient report to you how hard it is for them to breathe. And then you always document that in your note. Now, because COPD is air trapping, your patient's going to have a barrel chest, flattened diaphragm, stretched out non-compliant lung tissue. You're going to need to provide instruction on proper breathing techniques during activity. So what is proper breathing with COPD? Some of your patients are going to have orthopnea, which means they're using accessory muscles. And they also, orthopnea means you can't lay them perfectly flat. You put a patient that has a flattened diaphragm and a great big extended lungs, and you lay them perfectly flat, especially if they're at all overweight and there's the weight of their chest on top of their lungs, they're not going to be able to take in any breath at all. So orthopnea is very, very difficult breathing because of a loss of that mechanical advantage. and also because the pressure of their own chest when you try to lay them down flat. These patients need sometimes, in order to breathe, to be in a recumbent position. Many of them are sleeping at home in a recliner before they ever come to the hospital because that's the only way they can breathe. Now, speaking of difficulty breathing, this individual has all of the characteristic signs and symptoms of one of the diseases that we've talked about. Okay, look at him. Now look at this diagram of the patient with emphysema. This patient is very, very thin appearance, has the barrel chest, is having to prop their arms on their knees. We call that tripod breathing. Let me go back to the other slide real quick. So this gentleman here is participating in tripod breathing. He does not have any cyanosis. His lips are just as pink as they can be. But this is something that patients with advanced lung disease will do, especially in his case. He does have COPD, but it looks like more the emphysema is the predominant form of lung disease. He's leaning forward on his hands so that he can better optimize his accessory respiratory muscles. You can see around his head and neck up here, lots of development of those accessory lung muscles. He's using his SCM and he's breathing hard to try to get that air to exchange. You also are learning a new word here, cachexia, and you're going to see that on one of our case studies that I give you later on. Cachexia is a wasting syndrome that occurs with patients that have this advanced respiratory disease. And it means that there is an extreme loss of weight and atrophy, fatigue, weakness, and it's all because of not only loss of appetite, okay? They're not trying to lose weight, but they are losing weight like crazy. Well, why do you think that's happening? Number one, the work that they're having to do to breathe is, the workload is extreme. And so they also do not have the ability to exchange enough oxygen or get rid of the carbon dioxide enough to stop breathing long enough to chew and swallow. That if they're so dyspneic, is that a word? If they have such dyspnea at rest, then they can't stop breathing long enough to engage in a meal. So they have a lot of difficulty eating because of that. So cachexia is wasting in your advanced respiratory disease individuals. Paradoxical breathing is breathing that you will see again later on in a case study that we'll look at. Paradoxical breathing is very, very abnormal, and it's where a patient will draw in their abdominal muscles, and you'll see an upward thrust of their abdomen when they're trying to take in a breath. So it's completely the opposite of what you would expect. Normally the diaphragm's supposed to descend and the abdomen is supposed to poke out when you take a deep breath. And it's opposite with this individual. Lots and lots of accessory muscle use in this individual as well. And I would expect that in the patient we just looked at, that there is some paradoxical breathing as well going on in addition to the accessory breathing, because when it becomes a matter of survival, any way that you can exchange air is a good way. Abnormal diaphragmatic movement is or abnormal chest expansion is an indication for physical therapy getting involved with the patient in terms of breathing exercises. So depending upon the patient's diagnosis and comorbidities, there are 4 different kinds of ways we get involved with that. Pursed lip breathing, which is really good for getting air out. Diaphragmatic breathing, which is good for getting air in. Positional breathing, which means teaching them to sit up if they have difficulty breathing in a recumbent or supine position, or tripod positioning for increased use of accessory muscles. And then we also do some chest wall stretching and mobility activities to make sure that they're not compromising their ability to expand their lungs. Let's start by talking about diaphragmatic breathing. Correct breathing ought to involve your belly moving out when you take a breath and in when you exhale. Wrong breathing is to breathe up here in your chest. Oxygen is exchanged most efficiently, and the workload for breathing is the least or the most efficient when we use our diaphragm to move air in and out of our lungs and not use our accessory muscles, chest muscles, as well as rib cage. So when we teach diaphragmatic breathing, we usually ask the patient to put one hand on their chest and one hand on their belly just below their rib cage. And it's really, really good for post-surgical patients if they're not taking deep enough breaths. So good for lung expansion, and it's good to prevent pneumonia. We want the hand on the bottom to move, and we want the hand on the top not to move. If they're letting the hand on top move, they're doing it wrong. It can be taught in sitting, or it can be taught in supine or recumbent position. But reinforcing this with your patients, even if they're being seen by a respiratory therapist who's teaching them these skills, you're going to want to help them practice that while they're doing maybe their heel slides, or maybe they're practicing it while they're doing their ankle pumps. You want them still getting some carryover from instruction while they're doing their PT. The next one is called pursed lip breathing. Now, pursed lip breathing is real important for your patients that have COPD, asthma, pulmonary fibrosis. Pursed lip breathing decreases the workload of breathing because these people have hyperinflation, and when they try to exhale forcefully or even exhale normally the way you or I do, their airways will collapse and close up. So imagine you're trying to exhale through a straw and somebody pinches the straw. That's what it feels like when they try to exhale forcefully. You teach them to relax, of course, their accessory muscles, and you want them to take a slow inhale through their nose, 2 counts, and then they have to breathe out really, really slow through pursed lips, counting at least to 4. If they can't control their breath just by you describing blowing slow through pursed lips, you can tell them that they're trying to blow on a spoonful of hot soup and not make it fly out of the spoon, or they're trying to flicker the flame on a candle without blowing the candle out. So in order for them to get the air out without collapsing those airways, they need to let it out very, very slowly and against resistance. So when they purse their lips, they're creating resistance to the flow of air out here so that they don't have their airways collapsing in the process. A list of common pulmonary medications. Many of these we've already talked about with the heart cardiac conditions, but bronchodilators we didn't talk about. Those can sometimes increase the patient's heart rate. If you've ever taken a breathing treatment or used an inhaler, you know it can make your heart race and cause some arrhythmias, so be aware of that. The rest of these I think you're pretty familiar with, maybe except for mucolytics. Mucolytics are the ones like that thin out the thick, sticky mucus. They create a thinner so that they can kind of cough it up. Let's see, next slide. There's a few more. This one actually gives you some examples of the different, so I pulled this table because it gave you some examples. Antihistamines you're familiar with because many of you take. Allegra, Benadryl, Claritin, you kind of know what those do. They can cause your blood pressure to drop though, so be aware of that you could have some orthostatic hypotension if you're on too many antihistamines. Anti-inflammatories drugs are going to be the kind that many of your patients with asthma are on so that they don't get the inflammation or even bronchitis. And bronchodilators are supposed to open up those airways. Albuterol is the one that you hear most frequently in the breathing treatments when they're given those in the hospital. Mucinex, you all know what that is, and guaifenesin. If you've ever needed an expectorant, or pulmozyme and mucomist are the ones that are mucolytics. They break down the mucus, help you to move those out a little quicker. Heard a lot about ventilators lately with COVID in the world. So be aware that when a patient is on a mechanical ventilator, they do have an endotracheal tube that's been placed down into their trachea, and a balloon has been inflated in order to prevent that from moving once it's in place, and to seal it off so that air can't come in or out around it. So an endotracheal tube connects the patient's trachea directly to this mechanical ventilator, which is used to breathe for the patient or to assist them. It can be put in two different modes. One is a positive pressure ventilation, where it's pushing the air into the lungs. The other is where the patient takes a partial breath, and if they're not able to fully inflate the lungs, they get a little bit of a breathing assist. If a patient has to be on the vent for a really long period of time, they'll go ahead and surgically place a tracheostomy in their cervical region into the trachea, and that's so that the patient doesn't have to be on an endotracheal tube forever. It just gives them an alternate airway. Patients with lung diseases that are on a ventilator will still get buildup of mucus plugs. Sometimes the mucus will get up into their endotracheal tube, and these patients need to be suctioned. So suctioning is indicated anytime you hear abnormal breath sounds like drooling or gurgling sounds in the, bubbling sounds in the respiratory tract each time they take a breath. They will have a very ineffective cough, and they're not able to clear those secretions out. So the endotracheal tube or the trach is going to have suction tubing already attached to it that can be like lowered down into the trachea, and as you pull it out nice and slow, it suctions out all of that gunk so that the patient can begin to exchange oxygen again. Well, you'll get to see a patient or a mannequin on a ventilator when we go to the simulations lab, and I'll have one of the nursing students demonstrate how you would suction that patient. Many of you have heard of BiPAPs. But this is a piece of equipment that provides positive airway pressure. So it's in two different levels. So it encourages a breath, and then there's a period when it's not blowing. And so it's going to be kind of on and off, administered through either a nasal cannula or a nasal and mouth mask. There's different kinds of, head attachments. But the pressure is higher during the person's inhalation and then lower during their period of exhalation. Recently, there's been some good research about the use of BiPAPs on patients that have COPD during exercise, showing that improves their ventilatory function, and it improves their ability to maintain good air exchange and good O2 sats during exercise. CPAP is a continuous airway pressure, so it just blows all the time. You typically are going to see these on your patients that have sleep apnea, or they snore really bad, and those periods of apnea can be really scary. So the sleep studies will be conducted, and most of them will make it home with a CPAP. They're supposed to sleep in it every night. Most people who have a CPAP, it ends up in their closet. unless they're really fearful of stopping breathing in the night. All right, next we have pulmonary function tests. You'll see PFTs or pulmonary function tests ordered on your patients that have pulmonary disease. These are breathing tests where information is collected during inhalation, exhalation on different volumes. One of the main ones is forced expiratory volume at 1 second. So FEV1 and then FVC, forced vital capacity. These measurements can be compared to norms of that person's same sex, age, height, and weight, and be used to determine just how bad their respiratory condition is, and or how advanced their disease is. So looking at this table that came from the American Thoracic Society, these are some norms that were published that break it down into the percent of what's predicted. Like if they've got greater than 80% of what they should have, then that's 60 to 80 is mild disease. If it's 50 to 60% of what their age and gender and weight, whatever norms say that it ought to be, then that's moderate disease, and then less than 50% is severe disease. And you can see that it's a little different for FEV1, and I didn't even mention this last one, so that's not super important for you as a PTA, but it is the diffusion capacity of carbon monoxide. And that's associated also with lung disease, and I don't even know how they measure that. You will see that I've asked you not to memorize these values. I just simply want you to know what was on the last slide, is that pulmonary function tests are used to determine the severity of a person's pulmonary disease, whether it's mild, moderate, or severe. If you were a respiratory therapist, I'm sure you'd need to have all of this memorized, but don't do that for my test because it won't be on there. Okay, so on the remaining slides for this presentation, we're going to really focus on the physical therapy interventions and how you're going to be directly impacting this patient's care. First off, let's just look at some general physical therapy type goals that you should expect to find within your plan of care. So we want to minimize range of motion loss or strength loss, as well as aerobic and functional capacity. It's important that we recognize that they might even have weakness of their muscles of inspiration. So we might be doing some training with their diaphragm. If a patient has been on mechanical ventilation for a while, then anything that we do to improve chest compliance and to increase the strength of that diaphragm is going to improve their quality of life as well. So education on different types of breathing techniques, respiratory and peripheral skeletal muscle training and strengthening, talking about things like just improving the distance that they can walk and teaching them how to maintain their functional level while still managing energy conservation, managing their shortness of breath or dyspnea with exertion. Precautions that we're going to have are always going to require that we monitor this patient's vital signs and also their pulse oximetry. We're watching for desaturation or any rise in their CO2 that would cause them to exhibit any cyanosis, fatigue, and other kinds of signs and symptoms that would make us want to either slow down a little bit or terminate physical therapy, such as claudication or just extreme dyspnea with exertion. We've got to work around certain types of complications related to them being on mechanical ventilation that can cause them to desaturate pretty quickly as well if we're working with those patients. A 6-minute walk test is a standardized instrument that we use on a lot of patients, not just pulmonary patients, but it's a good one for your pulmonary patients because you have a patient walk for 6 minutes and you're measuring different things during that time frame. It can be used to quantify how they're doing with their oxygen saturation, so it'd be critical to measure that. If the patient were to become hypoxic, which means that they drop into that 88 to 92%, which is with your pulmonary patients, something we watch for. As long as there was an order, we would stop and rest, or if it were okayed by the respiratory therapist and the physician, we could titrate that oxygen in order to maintain improved SpO2. Red flags for your pulmonary patients, according to American Physical Therapy Association, would be drops below 88 to 90%. They give a little bit more leeway with these patients that are on supplemental oxygen. Typically below 90 is what we would consider a red flag. But with your pulmonary patients, they desaturate so easily and with very little exertion that we don't want to get alarmed too quickly. We are watching for dyspnea, and I'm going to share with you a dyspnea scale in a moment. That the red flag on that scale is if they exert up to the point of 6 to 8 on that 10-point scale. That would be a termination criteria. And then if their respiratory rate gets up over 45 breaths per minute, that would be a red flag to terminate any physical exertion. So relative contraindications, respirations over 35 is already a little bit abnormal as well, but again, we consider that a relative contraindication because depending upon how advanced a patient's pulmonary disease is, they may get to a point where it would really be very little exertion at all for them to get up into that 35 breaths per minute. So that would be something that would indicate you need to be much more carefully monitoring their breathing. Again, if they have other coexisting conditions, comorbidities, such as obviously untreated cardiovascular disease or respiratory infection like pneumonia, hypertension, right heart failure that's causing them to take on a lot of fluid, diabetes, osteoporosis that would have caused them to be on prolonged steroid use. All of those things could cause you to want to monitor your exercise much more carefully. In the second list here, we have obesity, BMI of greater than 30, or cachexia, which is that extreme muscle wasting, and anxiety secondary to breathlessness. One of our goals with exercise is to be able to keep them within a good range by titrating their oxygen so that we can improve their exercise tolerance. That's going to make it easier for them to breathe at rest. So we want to create a bit of an overload, but we want to do that carefully. Patients that use assisted devices, that will increase their workload. So you're going to want to teach them to pace their breathing activities with exercise in order to help them with that shortness of breath. And then if you have a patient who is going to be exercising anywhere there is high humidity or high temperature, you would want to make sure that that patient knows that it's much, much safer for them to be somewhere where the air quality is cooler and filtered, like inside on a walking track or even in a mall, something like that. All right, next we're going to talk about how you train your patients, aerobic training of a patient with pulmonary disease. Okay, so we don't use target heart rate in order to monitor how they're doing. And you've heard me talk about a dyspnea scale, and I said I would show it to you in just a few moments. So 6 to 9 was a termination criteria. Now I'm telling you that the recommended intensity is 3 to 5 on that dyspnea scale, which means moderate to severe or heavy exercise. So increased activity is tolerated within that range of 3 to 5, where the patient can comfortably monitor or control their breathing. And you want that relative perceived exertion scale to also be in the 3 to 4 range on a 0 to 10 point scale. So we're going to review both the dyspnea scale and the relative or rate of perceived exertion scale here in just a moment, but this tells you where that patient needs to be when you're performing aerobic training. You start with really, really short intervals of training with these patients who get short of breath very easily, but your goal is still the same goal. You want to progress them up to 30 to 45 minutes of continuous activity per session. Strength and endurance is also something that you're going to want to address with your pulmonary patients. You begin with very, very low weights if you were wanting to do resistance training, like less than 50% or up to 50% of their one rate max, and you don't even necessarily have to test their 1 rep max in order to know if something's very, very difficult for them, and then to back down to that 50% or so. High reps of low weights is what your goal is for your pulmonary patients. Okay, when they can do 12 to 20 with a certain weight and stay within their target range for their rate of perceived exertion and their dyspnea scale, that's where you want to begin. Okay, and you can gradually then work up anywhere from 50% their 1 rep max up to about 85%. And you can eventually lower those repetitions down to the 8 to 10 range. Okay, so you're starting with high reps, low weight, and you're working up to lower reps with a little bit higher weight as their strength improves. You want to also focus on straining their inspiratory muscles. And I'll show you some ways that you can do that on the upcoming slides. They want to do that about 30 minutes at least once a day, but you can divide it up into smaller time, 15 minutes per session and 2 sessions. But you want to work up to being able to do that a full 20 to 25 reps of each of those exercises. Flexibility is still really important with your pulmonary patient. Chest wall compliance being the most important. If they spend all of their time tripod breathing and leaned over, bracing their upper extremities so that they can use accessory muscles, then you're going to want to also work on some stretching and chest compliance. You might have them doing some PNF patterns and stretching their chest in supine. And also their back, including rotation and side bending. Gastrocs, of course, and hamstrings are going to always need to be stretched. Okay, back to our perceived exertion scale. We have found that anytime you have patients, cardiopulmonary patients, that are on drugs like beta blockers and some of those other types of medications that interfere with being able to use their maximum heart rate as a measure of exertion, we have to use something different. So that's what Borg's rate of perceived exertion is about. And it's been found through research that when a patient is able to give you, what the exercise feels like to them, does it feel like it's weak, moderate, strong, very strong, or extremely strong maximal exercise, they're usually pretty much on the mark. If it's a healthy patient that can also be measured based upon their heart rate, then they have found a high degree of correlation between those, so that this is considered reliable in terms of estimating where the patient's exertion would be if it were being measured by their heart rate. So many of those medications, like we said, beta blockers specifically, make heart rate response useless for monitoring because the patient's heart rate cannot increase with increasing exertion. So if you'll see, 3 to 4 moderate to slightly above moderate is where you want your patient exercising. That's your target for your cardiopulmonary patients. Now, the problem with Borg's scale is that when it originally came out, it came out on a 20-point scale that went from 6 being the lowest to 20 being the highest. And some places still use the original Borg chart, and they have that on the wall, which would mean that you would have to know how does the original 6 to 20 scale, how does that relate to the 0 to 10 scale. And so what I've done is I've found you a side-by-side, and light to moderate perceived exertion would be 3 or 4 out of 10. Or what we said on the last table, if we want them at the 3 to 4, which on the 10-point scale is moderate, then we're going to want to look at right around here in this center green line. So we'd be looking at 11 to 12, or I'm sorry, 10 to 11 on the original Borg, and we'd be looking at 3 to 4 right in the same area for the 1 to 10. So light is when a person should be able to hold a conversation easily while they're doing what they're doing. Moderate to somewhat hard means that they're breathing more heavily, but they can still hold a conversation. So you always want to document whether you're using the original 6 to 20 Borg chart or whether you're using the 1 to 10. Because on the 1 to 10, we're still going to be reporting the same amount of exertion even if we're using a different chart. So just make sure you always report which chart you're using. So you would do that like relative perceived exertion was reported by the patient to be 5 out of 10. And if you were saying it was 5 out of 10, you would be saying 12 out of 20 would relate to a 5 out of 10. Okay, incentive spirometry. You've seen these little gadgets in patient's room. This is used to help a patient remember to take really good deep breaths after surgery. Sometimes when a patient has had surgery, they've inflated their abdominal cavity with gas, they've cut them open, they've got incisions, and it can be very, very painful to take a deep breath. So patients will take little shallow breaths instead, and that can cause them not to be fully inflating certain segments of their lungs, and they can end up getting pneumonia by not fully using and inflating those air passages and those alveoli. So this helps keep their airways clear and helps keep preventing the fluid to build up, causing pneumonia. Patients should be given this and asked to use it at least once or twice per hour, a good full 10 reps. And remember that this is an incentive spirometer, but it's for inspiration. So you can set a target. Usually the respiratory therapist sets the target by moving this little yellow target up and down on the scale. When the patient breathes in through the spirometer, it's going to elevate the piston over here on the left-hand side. And they want to elevate that piston up to a certain volume, and they're supposed to try to hold it there while they inspire and count to 10. Let's look at the next slide real quick. The indications will be anytime a patient has had post-operative complications that make them not want to breathe deep, or prolonged bed rest, particularly post-surgical COPD, upper thoracic surgeries, abdominal surgeries, chest tubes, and cabbages. Those are going to really be good reasons to want to encourage the patient to use this. Pulmonary atelectasis or risk of atelectasis would be all of these as well. If they have a thoracic binder or bracing, let's say they've had lumbar surgery and they're in a brace that kind of holds them in tight, they might have restrictions that make them not fully inflate their lungs. Restrictive lung conditions, any restrictive lung condition. Patients with dysfunction of the diaphragm or the inspiratory muscles due to either a spinal cord injury, paralysis, or other types of neuromuscular diseases. 10 breaths every hour while awake is the typical frequency that is ordered on the chart, and encouraging that each time the PT walks in the room. Have you used your spirometer in the last hour? If you haven't, let's go ahead and use it before we try to get up. Get those lungs inflated and exchange some good air for some old air, and that'll help you with your breathing when we get up and do your PT. Also making sure that they have been given proper instruction and that they're using it correctly, so you can follow behind them and ask them to let you see them use that spirometer, and you can encourage good use. So here's again, the piston needs to rise and be held at the location of whatever target's been set. Feet on the floor, sit up. Make sure that you're sitting up straight so you've got as much lung volume as you can access. And after each set of 10 deep breaths, you're going to want to cough and, clear any secretions from the airways that you can get up. If you have an incision, support that incision with your pillow while you cough. Remember, we talked about the post-cabbage. They always have that heart-shaped pillow that they can hug against their incision. Okay, the next few slides are specific types of airway clearance techniques. Typically, these are going to be done by the respiratory therapist. They are not things that we have to teach per se, but many of these chest PT clearance techniques are going to be on your licensure exam. And for that reason, I'm going to teach you and have you watch some videos so that you will be prepared for those licensure exam questions should they come up. The first one is called active cycle of breathing. It was formerly known as forced expiratory techniques, and it is a breathing control where you start with gentle, normal breathing, which may be diaphragmatic, which we've talked about. So you get the patient breathing with normal diaphragmatic breathing. Then you're going to have them take 3 or 4 really slow, relaxed inhalations, passively exhaling, not forcefully. You may even add any percussion or vibration, which I'll show you on another slide. And then you have them do 1 or 2 really forceful huffs. And huffs are when you open the glottis and you huff out like that, so that you're trying to forcefully move any secretions. There's a really good video here that you can click on when you open your PowerPoint and are going through the PowerPoint. Watch that video so that you can be able to assist a patient with huffs if you should need to, or pass that question on your test. The next one is called an autogenic drainage technique, also used to move secretions. This is an unsticking phase, which is slow breathing, and then a collecting phase where there's tidal breathing, normal tidal breathing, with a 2 to 3 second hold of the breath, and then an evacuating phase where you go through a period of huffing. It's very, very similar, but again, watch that video. This is another video of coughing versus huffing so that you know the difference between the two. Please watch those videos. Percussion and vibration are also exhibited for you on this video so that you can get down. The hand are cupped in order to move secretions. That increases the vibration when that air is forcefully exchanged. That increases the vibration within the chest cavity when you use a cupped hand. Now talking about postural drainage. Postural drainage has to do with how you position the patient if you're going to apply any of these breathing techniques. Typically you would place the segment of the lung that needed to be evacuated in the up position, and you're going to position the patient based upon which lung segments have fluid in them. So prone or semi-prone would be used for posterior segments of the lung. Supine would always be used for anterior segments of the lung. Right sideline would be used for the drainage of left lung segments, and then feet elevated or head down would be used if you were trying to evacuate a lower lobe. Especially basilar lobes, you always have the feet up, that good 18 to 20 inches for the basilar lobes. There are a couple of weird ones, and the weird ones are the right middle lobe and the left lingular lobe. Of course, those are the weird ones anyway, and that would be the feet elevated 12 to 16 inches, and you would be a quarter turn off of supine with the bad lung still up to drain those segments. Looking more specifically, this picture comes from your O'Sullivan textbook, and it's the one, it may not exactly match the one you get in your spring licensure prep book, but it's going to be very, very similar. It always places the bad lung up, and it shows you for every single individual lobe of the lung why you're putting that piece of the lung up, and it's always to get that bronchopulmonary trunk to be the one that's most vertical, so that any collection of fluids as you vibrate or percuss over that lung segment, that liquid would all be draining directly into the main bronchus, so that could then be coughed up. So for the lower lobes, I want you to notice on the table how each one of them is going to exactly follow the bad lung up rule. If you're working on the superior segment of the lower lobe, then you're going to have the person in prone with no elevation of the feet or the head. They're just in perfectly lying flat, and you're going to percuss just below the scapula. That places that bronchopulmonary trunk in that vertical position for emptying. If you're working on the basilar segments, whether they're posterior, anterior, or lateral, you're going to have the feet up a full 20 inches, so that you're going to tip the patient so that the fluids are running from those basilar segments which touch the diaphragm down towards the bronchi. So if it's a posterior basal segment, they're in prone. If it's the anterior, they're in supine. Or if it's the lateral, then they're going to be that quarter turn off of prone. Each place that you are percussing is going to be directly over the segment. So the posterior basilar segment, you're going to be percussing just below the lower ribs. If it's the anterior segment, their arm is up and you're percussing just under the axilla over the ribs. And then if it's the basilar segment, again, it's at the lower ribs with them in that quarter turn from prone. Upper lobes, notice how, again, bad lung up rule applies. If it's the posterior segments, then they're in sitting, okay? And they're leaning forward. And let's see. Your book shows the person just in normal sitting for the upper apical segment, and for the upper lower segment, they slump forward in the supine position. And then for the anterior segment, you lay them in supine. Okay, I guess that's the very last slide we have for this PowerPoint. So how much emphasis am I going to put on your test on pulmonary and on pulmonary drainage? I'm going to give you a breakdown of how many questions there will be on that. I think right now it's going to be in the mix with everything else. So you do absolutely need to know what positions correspond to what segments, and whether the feet are up or whether your head of bed is flat, whether you're on your left side or right side. But I'm going to ask you questions so that if you were reading that multiple choice question, simply based on the bad lung up principle, you're going to be able to eliminate right off the bat at least 2 out of 3 of those multiple choice items. And then if you can remember when the patient has to be sitting up, or whether it's a basilar segment and their feet have to be up to 20, you should be able to eliminate down to 1 pretty easily. Okay, so what I really want you to do is memorize the rules. Bad lung up. If it's touching the diaphragm, feet have to be elevated at least 20 degrees, and superior segments, the patient's either sitting up, or if it's that anterior segment, supine with the head of bed flat. So try to keep those questions as straightforward as I can, not any super confusing ones. All right, that's it for the lecture on pulmonary conditions. It's a lot of information, but again, we will be doing some case studies in the sim lab of patients that have pulmonary conditions. So do look over that, and I will see you guys in lab. Thanks.